we can probably all agree that any false positive test result is bad. But I think it's safe to say that some false positives, like a false positive HIV test, for example, is much more anxiety-provoking than others. And when it comes to HIV, there have been a number of key advances in the field over the past decade, including the development of improved diagnostics and optimized algorithmic approaches, all of which have allowed for earlier detection of infected patients, and particularly those with acute HIV. Among these advancements has been the development of fourth and fifth generation serologic assays, which, as our guests will discuss, offer multiple benefits over prior assay versions. But unfortunately, these assays are not immune to the possibility of false positive results. So confirmatory testing remains a necessity. The challenge, though, is that depending on the institution and the environment and whether there's a worldwide pandemic going on, the turnaround time for such confirmatory testing can be prolonged, leaving patients and clinicians in a kind of diagnostic limbo. So is there a way to minimize the risk of false positive first-tier HIV serologic test results? And that is the question that we'll be talking about and trying to answer in our discussion today. So welcome to Editors in Conversation. I'm your co-host and JCM editor, Ellie Thiel, and I'm here, of course, with JCM editor-in-chief, Dr. Alex McAdam from Boston Children's Hospital. Hello there, Alex. How are you?
I am fine, and I'm very fired up about the podcast today, and I'm fired up because I feel like meetings are not too far off, and I am missing meetings. I am ready to go back. So I have ClinMicro open in just a couple of weeks, which is a very small meeting that I'm really looking forward to. Then there's a pause, and then I've got the molecular virology workshop from Pan American Society for Clinical Virology. And then that's followed by the mother of all microbiology meetings, Microbe, which I am really looking forward to. I'm convening a good session with Ben Pinsky. I'm speaking on a panel. So I am ready to go back to meetings. How about you? Are you fired up for the meeting season?
I am. I mean, we're kind of in our meeting dry season.
Yeah.
Nothing really happens during the winter, so I'm ready to go. And all of these meetings are in the South, where it's going to be nice and warm.
Yep.
Unlike Boston and Chicago, where our guests are from, and Minnesota. So I'm with you. I'm ready to go.
I might be in the warmest city of the podcast today.
Yes, you might be. Yep. So Alex and I hope that you've enjoyed previous Editors in Conversation episodes, and we ask that you please subscribe to the podcast and review. And this episode, as all of you routine listeners know, is brought to you by the Journal of Clinical Microbiology, which is available at jcm.asm.org and on Twitter at jclinmicro. The podcast is supported by the American Society for Microbiology, which publishes JCM. And if you are considering publishing in the journal, you'll be happy to know that ASM members get up to 50% off of publication fees, which is a nice bonus. And you might end up on the podcast, which is free of charge. So that's also exciting. So with us today to talk about their recently published paper entitled Utility of the Signal to Cutoff Ratio and Antigen Index from 4th and 5th Generation HIV 1 and 2 Antigen Antibody Assays for the Diagnosis of Acute HIV. It's a mouthful, but the paper's really good. We have two first-time guests to the podcast that I'm excited to introduce, starting with Dr. Shivanjali Shankaran, who is an assistant professor and ID clinician in the Division of Infectious Diseases at Rush Medical Center. Welcome, Dr. Shankaran. We're very happy to have you join us today.
Thank you. I'm very happy to be here.
Wonderful. And then also with us is Dr. Beverly Shah, who is the senior author on the study. She is a professor of medicine also in the Division of Infectious Diseases at Rush Medical Center. Thank you, Dr. Shah, for coming on the podcast as well.
Happy to be here.
Great. So I guess we'll just go ahead and dive in.
Let's do it.
Shivanjali, first question for you today. Can you kind of set the stage for us and give us an update on what the current state, kind of current stats are for HIV in the U.S. and what's kind of the current focus when it comes to a infection control perspective?
Sure. So worldwide, about more than 38 million people are living with HIV. And as of the end of 2019, almost 1.2 million people were living with HIV in the States. In 2020, there were more than 30,000 new diagnoses, and the good news is that that number is actually lower than the year prior. However, one of the estimated numbers is that 13% of people living with HIV in the States don't actually know about their diagnosis. As listeners may be aware that when people living with HIV are on antiretroviral therapy and they're undetectable, they're not able to transmit the infection. That's the basis of the U equals U campaign, which means undetectable equals untransmittable. So the majority of the new cases can be linked to people who don't know about their HIV diagnosis. So the control sort of campaigns are all multi-pronged, education for healthcare providers, the communities at risk, people living with HIV, increasing access to and helping people stay on PrEP. And one of the very important parts of that is increasing the diagnoses, the number of people who are diagnosed by increasing access to HIV testing, both in healthcare settings as well as in community settings, because once we know someone has HIV, we can get them on treatment, help them get to undetectable, help their health, and also help the population.
Thank you. And both in your paper and in what you've just said, you talked about the need for expanded HIV testing, linkage to care programs, and the importance of initiating therapy. Tell us how that works in your clinic. Give us fill out the details of how this works concretely.
Sure. So the CDC recommends that everyone 13 to 64 get tested for HIV at least once. It can be in any healthcare setting. But some of the issues are the provider has to remember, in addition to many other things that they're dealing with. And then they have to be able to inform the patient, bring them in, and get them started on treatment. And so we, under Dr. Shah, devised a way in conjunction with the ER, where in our electronic medical records, if certain criteria are met, meaning the person's between 13 to 64, they don't have a diagnosis of HIV and don't have an HIV test in the last 12 months. If a blood test is done, then an automatic HIV test also gets ordered. And then the provider has to either sign it or cancel it if maybe the person already has a diagnosis, for example. When the nurse is drawing the blood, she informs the patient. And then, of course, the vast majority of the tests are negative. One of the prior papers, we have a 0.7% prevalence rate. But when there is a positive test, there's a pool staffed by some of the ID physicians, including Dr. Shah and myself and our nurse. And then we reach out to the patients to either get them back into care. A significant percentage of those patients know about their diagnosis and are either seeing somebody or were seeing someone. And so we help them in getting back into care. A lot of times it's at Rush, sometimes it's at other facilities as well. And then if it is someone who has a new diagnosis, then we bring them in as quickly as we can, counsel them. We have a dedicated social worker who will try to come and talk with us just to help with, it's probably the worst period of that person's life at that moment, unexpected. But she also helps with resources such as insuring insurance. A part of it is helping with travel accommodations. And then we have a pharmacist who's able to help us get patients started on medications as soon as possible. Mm-hmm. And so by sort of having these sort of steps that can be followed, and a lot of the steps are automated, we've tried to increase the number of people getting tested and also help with bringing them in and starting them on treatment as soon as possible. When we look back at some of our, I think 2016 to 2018, we were able to increase the percentage of people being tested from 2.5% of eligible people to almost 17%.
Wow. It sounds like you guys have a really well-rounded kind of process and system in place. So that's great to hear. So kind of with that background, I think we'll move on to diagnostics. Shivanjali, can you refresh us on the current testing algorithm for diagnosis of HIV?
Sure. So we have the screening tests. The ones available now are the 4th and 5th generation tests. And if they are positive, then most places have a reflex by which the confirmation test, which looks for antibody, is done. And then when both of those tests are positive, the person has a diagnosis of HIV-1 or HIV-2. As is the sort of basis of this study, in some small percentage, we can have a positive screen. which is the fourth or fifth generation test, and a negative confirmation test. And having the fourth generation and the fifth generation test helps us with increasing the people that we identify, but also identifying people earlier in the stage of the infection.
Right. And so if those two first and let's call it second tier tests are discordant, additional testing, including molecular testing, is done. So can you talk a little bit about the time to positivity for the different assays?
Sure. Some of the third generation tests had a 20 to 30 day time to positivity, up to 6 weeks, but with the fourth and fifth, we're able to cut that down quite significantly to 15 days or sometimes even less. By having the P24 antigen as a part of the test, that helps to identify people really early during the acute phase of the infection so that we're able to hopefully get them started on treatment as soon as possible.
Right. And I think you kind of alluded to this, but one of the key differences between the fourth and fifth generation assays, right, is the fourth generation looks for antibody in P24 antigen, but does not differentiate between which is detected, versus fifth generation assays, which allow for that differentiation, which is important when we get into your paper.
Just to follow up, can you tell us some of the causes of discordant serologic results between fourth and fifth generation test results and the supplemental assays? And are there challenges with the algorithm that you described?
Sure. We may not always know exactly why it happens, but one part could be an issue with the lab test itself or contamination. But some of the main reasons are if there's an intercurrent viral infection, such as infectious mono or the flu. And they've also published cases of false positive testing in people who are acutely sick with COVID-19. Multiparous women, they may have multiple antibodies in their serum, which could cross-react as well. Having positive autoimmune serology, such as ANA or rheumatoid factor, can also lead to that false positive testing. And so I think because this is such a multi-step process, it's essential to have reflexes so that if one is positive, the next one reflexes. And then if you have that discordant result, then a molecular test or the RNA also gets reflexed, because if that's not there, then someone has to come at the back end and add it on or call the person to get that testing done. Many facilities or many labs already have that in place where they'll do a qualitative HIV RNA with that discordant test so that they're trying to decrease the time it takes to get a diagnosis one way or the other.
Awesome.
And just from both of your experience, you just described what happens when there are those discordant results and the follow-up testing. What's going on with the patient during that window of time? How are they doing? How are you communicating with the patient in that window?
I can try and answer that question. So
Thank you.
I think it depends. We did subsequently implement testing in our outpatient setting as well. And on the outpatient setting, many patients are more tied into the electronic medical record. So they're actually looking at their tests in real time, and we have another provider involved. So one thing we have done is reach out to them, and the signal to cutoff ratio is not reported on the lab test itself, but it is something at the back end we are able to get from our microbiology laboratory. And so we can at least kind of convey that information and say, hey, we suspect this may be a false positive, additional testing's being done. We can help them reflex to that viral load if we have plasma on hand, or advise them to bring the patient back in, but tell them it's likely a false positive. If it's obviously high and we're concerned, we will tell them we need to do additional testing to determine, is it a false positive or does it represent acute HIV?
Mm-hmm.
Thank you, Beverly. So frank and open communication is the key, it sounds like.
Yes.
Mm-hmm. Yeah.
Go ahead.
I was just going to ask Dr. Shah to kind of, with all that background, take us into the study and kind of describe the goal and the overall approach that you guys took to look at that.
Sure. So, this actually started as kind of an offshoot of a workflow we had created to try and recruit patients for an AIDS clinical trials group clinical trial that was assessing the benefit of very rapid HIV start in persons identified to have acute HIV. And to meet criteria to enter the clinical trial, they had to have discordant testing, so a positive HIV antigen antibody, and then a negative confirmatory antibody. And then one could either get in by having a positive HIV RNA or a signal to cutoff ratio of greater than 10. And because our laboratory typically only runs the HIV RNAs 1 to 2 times per week, that was too slow to try and identify and meet inclusion criteria. So we started to use the signal to cutoff ratio. And we found that it actually was very helpful to identify these patients. In Chicago, there is kind of a network of clinics and certain hospitals that are involved in linkage to care and trying to expand testing. And we meet quarterly. I presented some of this information at one of those quarterly meetings. Dr. Petrak at the University of Chicago, who is also a co-author on this paper, heard me speak and thought it was very interesting. And we decided we should do a look back and see how effective this was over a larger number of patients. So that resulted in this manuscript.
Sounds like the start of a wonderful way to start a project. These offshoots from other larger studies. So that's great. Shivanjali, other studies have looked at the signal to cutoff thresholds of these assays in kind of an attempt to differentiate acute infection versus established infection. So can you talk a little bit about what they've found and how your study is different from those?
Sure. Yes, as you mentioned, there are several studies who have looked into this, and they've looked into it in specific populations, such as in pregnant women. Many of those weren't necessarily with the discordant result. They were more looking into was this a recent versus an established infection. The study that Bev had mentioned, in that they also used the signal to cutoff ratio, but they used a higher threshold of 10. Whereas with our paper, we found the high sensitivity with a lower threshold of 3.78. And also with this, because we have the 5th generation testing results available as well, we were able to identify the antigen index, which has the really high sensitivity. And I wasn't actually able to find a lot of papers that use both the signal to cutoff ratio as well as the antigen index to help with differentiating between acute HIV and false positive tests.
And Beverly, this study was a retrospective study done at 2 different institutions. Can you just give us a summary of the patient population? Where were they initially seen? What was the breakdown of patients in terms of who had acute HIV versus those with falsely positive test results?
Yeah, so at Rush, where we use the 4th generation Abbott test, our screening program is in 2 of our emergency departments and then in more than 60 outpatient primary care clinics across the Rush systems of health. And at the University of Chicago, their screening mostly occurs in the emergency department, but they do also do some screening in the inpatient side and outpatient settings. At Rush, we did provide more participants or patients to this manuscript. We had overall 88 and reported over a longer period of time of 77 months. And that is because we actually began to use this clinically to help us. At the University of Chicago, because they are using the 5th generation, they do have that. They know whether the P24 antigen is positive or not, whereas we do not with the 4th generation. So they provided data on 39 patients, but over an 18-month period of time. And between the 2 sites, we did have 38 patients with acute HIV and then 89 with false positive results. So, that's a larger number than has been previously reported for acute HIV patients compared to other papers that are out there that have looked at this.
Yeah. Thank you for that. So one thing I thought was interesting, roughly 2/3 of the false positive results were in females in both sites. So I thought that was curious. Can you talk about why that may be?
Yeah, I mean, I think, Shivanjali mentioned some of the reasons why we do see false positives. And it is true, if you look at who was tested, it was pretty equal between numbers of men and women. And both
Hmm.
sites did report more false positives in women. I mean, we certainly know pregnancy is a condition where HIV testing is going to be occurring, and women do have more autoimmune diseases and disorders than men. So my suspicion is that is probably driving the
That's
higher rate we're seeing in women.
got it. Thank you. So, diving into the data, can you kind of walk us through what you found with respect to the signal to cutoff ratios for the fourth generation assay? Again, looking at false positive patients versus those with acute HIV, and then putting that into context to what the current signal to cutoff threshold is, specifically for the architect assay.
Yeah, so for the architect assay we used at Rush, as well as the fifth generation used at the University of Chicago, any value of either the signal to cutoff or the antigen index of greater than equal to 1 is considered reactive or positive. Um, and for our patients at Rush, the median signal to cutoff ratio for our 61 false positive patients was 1.61, so not too high above that 1 cutoff. And then for our acute HIV patients, it was 23.84, so significantly higher. Um, and we found that through receptor operator curve analysis that a cutoff of 3.78 would give us the best sensitivity and specificity as a cutoff.
Mm-hmm. Yeah. And then you also talked about looking at these signal to cutoff values relative to viral load, and looking to see whether there's some sort of correlation. Did you find anything there?
So for the Rush patients, we did find a correlation where the higher the signal to cutoff, the higher the viral load was in the patients with acute HIV infection. At
Mm-hmm.
University of Chicago, there were some slight differences where for those for their median antigen index for those with false positives, they had 28 with false positive readings. It was 1.07. And then for their acute HIV patients, of which they had 11, their median antigen index was 6.43. So again, higher, but difference was not as great as what we saw with the Abbott fourth generation assay. And their threshold that gave the best specificity and sensitivity was 2.83. In these separate analysis for their participants, the level of viral load did not correlate with the level of the antigen index, but again, they did have smaller numbers of patients, so it may have also been related to that. In addition, I would say the height of the viral load uniformly was extremely high in all these patients with acute HIV, and that is what we would suspect.
Thank you, Beverly. There were a number of patients who had elevated signal to cutoff ratios or antigen index values that were deemed to be false positive results and ultimately did not have acute HIV infection. Can you talk about those patients and what it might have been that led to those false positive
Yeah, so
results?
it was not a huge number, but at each site we had one distinct patient each that had quite a high level. At Rush, our patient was homeless, had come in for acute abdominal pain, and unfortunately, we did not know very much about him. His signal to cutoff ratio was extremely high, I think even over 40. And we deemed him to be a false positive because his viral load did return at less than 40. The other patient at the University of Chicago who had an antigen index of about 19 had widely metastatic prostate cancer. And neoplasms have been reported as a cause of false positive HIV tests as well. And I think, really anything that's probably activating the immune system that could be causing cross-reactive antibodies can cause these false positive readings.
Mm-hmm. So, Shivanjali, can you tell us a little bit about what the consequences would be of receiving antiretroviral therapy and, due to a false positive result?
Sure. Luckily, even compared to 10 years ago, the antiretroviral therapy we use is very well tolerated, and they have minimum to no side effects. And even in elderly patients or in people with underlying kidney or liver dysfunction, they're relatively benign. So, a few days of taking antiretroviral therapy is unlikely to cause a significant issue. There may be side effects such as headaches, stomach upset, diarrhea, or just not feeling well, fatigue. But most people don't have side effects, and certainly nothing that would be long lasting. It might be more, I think, as you mentioned earlier, being told you have HIV and starting on medication and then being told actually no and then being taken off medication.
Yeah.
Can be jarring for patients.
Yeah, understandably so.
Thank you. And Beverly, it sounds like you may already be applying some of these findings in your clinic. Is that correct, or do you have plans to apply some of these data to your clinical practice?
We actually are looking at the signal to cutoff ratio for all the tests we see that have a discordant result. So we will typically, as soon as a positive comes into our Epic inbox where they get routed to us, then the confirmatory test does get done, typically same day or mostly the next day. And once we see that it's discordant, we will reach out to our micro lab and request the signal to cutoff ratio. And then from there, move towards trying to get either a qualitative or quantitative HIV RNA test to determine, is this a false positive or a acute HIV?
Mm-hmm. So Beverly, it was a pretty kind of to the point, I thought, well done study. Can you talk about what kind of limitations you would say are key to take away from, and then kind of what's next? What would be the next step to kind of further and promote your findings?
Yeah, I think that one important thing to stress is that while the signal to cutoff ratio is very helpful, while you're waiting for a confirmatory testing, a qualitative or quantitative HIV RNA still remains the best test and the gold standard for truly differentiating a false positive from somebody with acute HIV. So the goal would always be to try and get one of those tests completed. But sometimes, particularly when we're seeing patients in the emergency department, it's just not possible to reach those patients, or they just don't want to come in. If we are able to add on a quantitative HIV RNA at our lab, we will do so if we have plasma remaining from a CBC that was obtained. But I will say, if we know the signal to cutoff ratio is high and our suspicion for acute HIV is higher, then we do spend more time and more effort to try and contact those patients versus if it's low and we see they don't really have signs concerning for acute HIV, we'll still make an attempt, but we don't drive ourselves crazy if we can't reach them.
Yeah, so it's really another tool to kind of help guide, risk benefit analyses. Wonderful. Well, thank you both for joining us today and for taking us through your study, really giving us some things to think about. And we hope for all the viewers that you'll join us for the next Editors in Conversation podcast, the topic of which has yet to be determined. So one of you listening might be on next. Alex?
Something with AST, Ellie, your favorite.
Okay, I might be on vacation. No, thank you, everyone.
Thank you.